Welcome to End of Life University on YouTube. Today I'm sharing with you an audio recording of an interview with Tim Johnston, who works for the nonprofit SAGE, which advocates for the needs of LGBTQ individuals. And we're talking about how to meet the end of life needs of the LGBTQ community. So I think you'll find this very interesting. And be sure you subscribe to this channel down below if you haven't already. Also, subscribe or follow the podcast End of Life University wherever you happen to listen to podcasts. And if you're able, make a small contribution to help keep this channel and the podcast on the air by going to eoluniversity.com/support. And there you'll find 3 different ways that you can make a contribution as little as a cup of coffee to help keep us going. And it means a lot to me. So thank you very much. And we'll move on with my interview with Tim Johnston. Hello and welcome to End of Life University podcast, where we share real talk about life and death. I'm your host, as always, Dr. Karen Wyatt, and this is episode number 230. In just a few minutes, I'll be sharing with you an interview I did with Tim Johnston of SAGE, S-A-G-E, and we'll be talking about meeting the needs of LGBT elders at the end of life. So stay tuned for that. It's a very important and interesting subject, and I know you'll enjoy my conversation with Tim. Before we start with that interview, I have a couple of announcements. First of all, I want to thank my latest supporters on Patreon, Amy Cunningham and Raven Butterfly. Thank you so much for stepping up and joining the team. And also to let you know, there's still 1 week left in the special offer on the Patreon page, which is at Patreon, patreon.com/EOLU. And this offer is to receive a free autographed copy of my book, What Really Matters, which is now out of print and not available for purchase. But I have a few copies left, so I'm giving them away to anyone who joins the team at the platinum level, which is $10 per month. So if you're interested in becoming a Patreon supporter and you'd like to receive a gift of my book, What Really Matters, while supplies last, go again to Patreon, patreon.com/EOLU. Thank you so much. And the next announcement is that my self-study course, the Death and Dying Class Instructor Training, is finally now available. So it's a 4-module course that you can take online on your own time, as fast or slow as you want to be with the course. And you'll learn how to put together your own class on death and dying issues. And it's really talking about the nuts and bolts of putting together a class, a workshop, or even a course, a full semester course, say for a college class. And so I'll share with you how to choose the best content for your course, how to structure the course, and even talk through some ideas for pricing and marketing your course in order to get students to attend. So it's packed with lots of information. Students who've taken the course in the past have gone on to create college courses and workshops and classes in their own communities. So if any of you are interested in teaching, go to the show notes for this episode at eolupodcast.com, and I will have a link there where you can learn all about the course. It's just $59 for the entire course. So go to the show notes for this episode number 230. You can also just go to my website, eoluniversity.com, and on the homepage, I will have some information there about how you can learn more about the course and register for it if you're interested. Also, if you're already on the mailing list, if you've already received the teaching guidelines by email, you will get an email about the course, and probably already have. So hopefully, if this is something you're looking for, this will meet a need for you. So now we'll move on to the interview with Tim Johnston. And as always, stay tuned after the interview, and I'll come back with a few of my takeaway points and to say goodbye. So here we go. Today, I'm happy to welcome my guest, Tim Johnston. Tim is the Senior Director of National Projects at SAGE, which we'll be talking about in great length during this interview. And he is responsible for overseeing SAGE's national training initiatives, managing federal and private grants, and providing consulting services to both aging and LGBT service providers. Tim is also the author of the book Welcoming LGBT Residents, a Practical Guide for Senior Living Staff. You can learn more about SAGE at the website sageusa.org, and we'll be reminding you of that again later on during the interview. So, Tim, thank you so much for joining me today.
It's my pleasure to be here. Thank you for having me.
Well, I've been very interested in learning more about SAGE as an organization and what it offers. So I thought we could start there by explaining, just for my benefit and for the listeners out there, what SAGE is and what it offers to people.
Absolutely. And I should say right off the bat that I won't be able to cover everything that we do, but I'll give you a kind of overview. SAGE is an organization that is over 40 years old. We are also the nation's oldest and largest advocacy organization working at the intersection of LGBT identities and aging issues. So a lot of our work historically and still today is kind of centered in the New York City area, where we do the bulk of our direct service work. So that could be providing meals, programming at one of our LGBT senior centers, and also things like case management. So that's a lot of what we do in the New York City area. But we also have a national affiliate network called SageNet, where we partner with local 501c3 nonprofit organizations to give them technical support. They use our name, and then also a lot of our programming to be reaching folks locally. And we do advocacy and educational work as well. So we do advocacy at the local, state, and also federal level to try to strengthen protections for LGBT older adults, and also make the aging network and funding streams more responsive to the needs of our constituency. And then the work that I oversee most directly is a program that we have called SAGE Care, which is our training and credentialing program. So we work with really anyone who works with older people, but we tend to kind of focus on hospice providers, home care, and residential providers to give them the tools and skills that they need to work with LGBT residents. So that could be everything from defining for a group of people what we mean by LGBT, which I'm happy to do here if that would be helpful, all the way up to more kind of complex questions around things like maintaining privacy and medical records for a transgender resident, or how to create programming at a senior center that would be interesting to LGBT folks.
And well, sure, as long as we're offering explanations and definitions, maybe you should go ahead and define what we are talking about when we say LGBT.
Yeah, absolutely. Just so kind of very briefly, the acronym LGBT stands for lesbian, gay, bisexual, and transgender. So lesbian and gay are words for women and men, respectively, who are attracted to people of the same gender. So a lesbian is attracted to other women, a gay man is attracted to other men, and also some women use the term gay as a kind of umbrella term for same-sex attraction. Bisexual describes folks who have the capacity to be attracted to both men and women, or people of multiple genders. So I do just want to take one brief moment to dispel a very common misconception about bisexuality, which is that to be a, air quote, real bisexual, you need to have the same amount of attraction for men and women, or be partnered or have the same number of relationships with men and women. And that's really not the case. It's about an identity and a term that somebody uses to describe the ways in which they're attracted to others. And plenty of bisexual people are in, long-term monogamous relationships, but that doesn't change the kind of orientation they have toward others romantically. So the first three terms are about sexual orientation, who it is that we're drawn to and attracted to. We would include in there as well the term heterosexual as a sexual orientation. That last term on the end, transgender, describes gender identity. So for somebody who's transgender, their gender identity doesn't fully match up with, or some people say isn't congruent with, the sex that they were assigned at birth, or how they were treated as a child and how they were raised. So, for example, someone who identifies as a transgender woman is somebody who was assigned male at birth. They were raised as a boy, given a masculine name and many times, but have come to understand that that's not the truth of who they know themselves to be. So they transition or come out as a transgender woman and then live their lives as a woman. Likewise, then, when folks use the term transgender man or trans man, they're talking about someone who was assigned female at birth, but who identifies as a man, and treating this person with respect in a kind of person-directed way would require acknowledging that person for who they are as a man.
And I think it's really important that we just talked about the definition of the acronym that we're using so that we remember the diversity within this population of people that we're talking about and how great that diversity is. And also to consider that when we're looking at the needs of people, we need to consider each person as an individual on the one hand. But I also recognize that there are certain needs and issues that may be common to this group of people, the LGBT community as a whole. And so that's something I wanted to talk about today, especially in terms of aging and facing the end of life. Some of the specific issues facing people in the LGBT community that may be a little different than other elders are facing. So could you talk about some of those issues?
Yeah, absolutely. And you're right that there is a lot of diversity within the umbrella of LGBT, and the experiences of a transgender person are going to be very different than that of a gay man. And again, I'll kind of highlight too that we have to be thinking of it not just in terms of sexual orientation and gender identity, but also other aspects of what makes us who we are. So being a transgender person of color is very different than being a gay person of color, for example, or a white lesbian. So kind of keeping that in mind is important. But to speak, kind of generally, I think one thing that folks should be attuned to is that while today we've seen some pretty significant advances in the inclusion of LGBT folks and the kind of expectation that LGBT people should be treated with respect, that has not been the case for most of the lives of our older adults. So if you're an 80-year-old LGBT person, you've spent the majority of your life in a cultural and social context where people told you that who you were was an illness, something to be fixed, something morally abhorrent. So these folks have really had to develop resiliency in the face of a lot of social pressure to try to change them or prevent them from being who they are. And what that means when we're thinking about somebody at end of life, or moving into a residential care community, or other moments when somebody is feeling vulnerable and needing help, is that they might approach that help from the assumption that they will be treated poorly. They'll look back at their history and think, well, I haven't had many good interactions with doctors, so why should I trust that this is going to be any different? And what that means is that they might not reach out for help. They might go back in the closet when accessing care. They might not bring a partner with them or not bring a friend to an appointment because they're afraid of how people will react. Or in the case of transgender folks, they might not be open about who they are and express their gender and their truth of their identity. So going back into the closet is one big problem. Another one that I'll highlight just briefly, and then we can keep talking about some other differences as well, is that because of the lack of marriage equality and also years of job discrimination, a lot of LGBT people have not been able to accrue wealth or work at the same level as some of their non-LGBT peers. So it's a population group that's more likely to be economically depressed and have some economic hardships, which then also can make it difficult to be accessing a lot of services and care that they might be looking for.
You mentioned the fear of discrimination from the medical community. And I, as a doctor, I'm certain that's real. And it may not be overt discrimination, but more a discrimination that comes about because of ignorance and doctors not even recognizing the needs of an LGBT person who comes in and longs to be open or wishes to ask specific questions, but doesn't feel comfortable because they haven't been welcomed in a way that would tell them that they're safe asking what they need to ask and talking about what's really going on for them.
Yeah, I mean, I tend to think of these things in a medical context as almost like three different levels of what folks might be experiencing. And I'll give you an example of all three. It's definitely still the case today that there are some people who simply refuse to provide care to members of the LGBT community or who provide them with substandard care. So we do still see examples of just kind of bald-faced discriminatory and unequal behavior. Especially, this is especially reported by transgender folks. So, I do want to recognize that while it is not as frequent as maybe it would have been in the past, that is still the case today. Then kind of one level up from that, there's care that isn't responsive to the needs of an LGBT person. So, for example, a transgender person who's going in for maybe they have bronchitis, they've got a cough they can't get rid of, and suddenly they find themselves in a situation where they're being asked questions about their hormone use or if they've had any kind of surgery, that kind of inappropriate care. I know another woman, a lesbian woman, who never felt like she could come out to her primary care provider. So that primary care provider had been writing her a prescription for birth control for the past 40 years, not understanding that she was engaged in one of the most foolproof forms of birth control, namely having sex with another woman. And then the kind of third example that I'll talk of is things that a provider might be doing that they don't realize is having a chilling effect on the relationship. So if I go into an appointment with my partner and somebody makes the comment, "Oh, would your brother like a cup of coffee?" That to me right there, it doesn't have any negative intent behind it. In fact, the intention is probably to make me feel welcome. But because that person isn't looking at me through a more expansive lens, they're not capturing the reality of what might be happening in the relationship. And they're letting assumptions get in the way of really getting to know me as a patient.
Yeah, that's fascinating. And that reminds me of many years ago, I had a transgender patient in my own clinic office. And I remember feeling not judgmental at all, but feeling inadequately trained and not even knowing for sure what should I ask about and not even knowing how to address it and how to be helpful and of service. And there was clearly a discomfort on my part during our interaction, but not because of judgment, only because of feeling uncertain, never having been trained or having had the advantage of learning about the issues of transgender people. So that's one of the reasons I really wanted to have this conversation so that we can help others feel at least like they've received some education here in how to do a better job.
Yeah, absolutely. And that's precisely why in our Sage Care training program, we start from the assumption that people want to do their jobs well, and what they need is information to do that. I think some really practical advice that I can give is that it's good to normalize asking people what name they use and also what pronouns they use. You can work that into intake forms, you can work it into initial conversations, but then you're not in a position of, for example, accidentally using someone's legal name when they go by a different name because they haven't changed their documentation, or trying to guess if they go by he, she, or they. You can just kind of make it normal and casual for people to share that information, which gets you good information, but also then sends a message to the person that you've thought about this and creating that more intentional space. And I think too, I'll just add that when I'm training, I never want people to get caught up on the idea that the goal is to be perfect and to get every interaction right. But instead, it's about creating that sense of partnership. So you might be working with someone and think, whoosh, I haven't had very many LGBT clients. I think it's really appropriate in a conversational setting to say, like, I want you to know you'll be treated with the utmost respect here. I'm really open to your feedback. Let's build this relationship together.
That's a great idea. I love that idea of just actually learning together side by side, which is really the approach we want to advocate for here in healthcare anyway, with all patients, is creating a teamwork atmosphere that we're here to work on your issues together, and you might need to educate me about some of your needs that I'm not intuitively understanding.
Yeah, the the only caveat that I would say to what I just said is that what I teach people is, if you're going to ask someone a question, especially a personal question, only ask it if you have a clear professional need for knowing that information. So what you want to do is use that as a kind of heuristic to help figure out, okay, is this question about the care, so the person really should be teaching me, or is it about my own curiosity? So I'll just give you an example using myself. If I'm with my PCP and they're my primary care physician, and she's asking me questions about my sexual activity, it's perfectly appropriate for her to be asking, specifically, what sex acts am I engaging in? But my optometrist doesn't need to be asking me that information. So I think that's a good question to ask yourself to make sure you're not inadvertently overstepping.
That's a very good point, and thanks for mentioning that. Yeah, that's an excellent point. Tim, I wanted to bring up just a couple of other things, because I have family members who are LGBT people, and I've been very concerned as I've watched them age that if they ever have a sudden health emergency and are in the ICU, that their partners may not be able to visit them or even be involved in the decision-making process about their treatment. And that's something I feel very alarmed about as a healthcare provider. And I wanted to ask you if you see that as an issue as well.
Definitely, and especially when we begin to think about hospice. So for a lot of LGBT folks, they might not have ever gotten married, but still be in long-term partnerships, and they might not understand what some of the legal distinctions are in terms of who will be their automatic medical authority or power of attorney should they become incapacitated. So I think with your family and with your patients, it's really important to make sure they've sorted out what they need to do in terms of putting the correct protections into place. Because if someone is in the emergency room, they should be able to designate who can visit them and who can't, and somebody who is a partner should be able to gain access to that person. But what might happen is that a biological family member might re-enter the equation and try to keep someone out of that space. And that's the kind of thing we see happening in hospice contexts, where the LGBT older person might have, frayed or poor relationships with their, children or their family of origin, if they're not accepting of them as LGBT. And then when they move into the hospice context, if they don't have those protections in place, the family members can come in and try to remove the partner from the equation, or prevent staff from dressing their parent in the way that they want to be dressed, or addressed by the name that they want used, because they're not accepting of that person's LGBT identity.
So, how can I be helpful as a hospice provider in a situation like that?
My first, and I think foundational recommendation, is when you're meeting a new client, ask the question, who are the most important people in your life? So that question, because it's really open-ended, will allow them to talk about a roommate, a cousin, a friend, somebody who might not fall into our common definition of family, but who in fact is one of their main supports. So for example, they say, oh, I've had this roommate for many years, we're very close. That roommate might in fact be a partner, but they never have to come out to you as a couple for you to initiate a conversation around, like, oh, you seem really close to your roommate. Is your roommate on the lease, or would you like your roommate to be your power of attorney because you don't really see your kids that often? You can help to get those protections in place because you started from that point of curiosity. Whereas if you begin the conversation by saying, "Are you married and do you have kids?" that might shut down the client, and it might prevent them from recognizing the work they need to do to preserve their relationship and their care going forward.
And I think that's a great way to pose the question to anyone, really, because a lot of people may be estranged from their children or family for any other reasons as well. And it's nice to ask the question in a much more open way so that we find out, first of all, who matters to you most that you want to be here with you. And then we can go into other more detailed questions after that. But I think that's a really lovely approach to asking about that.
Yeah, you'd be surprised what people tell you when you ask a question like that. Suddenly you figure out the person they see most often is the mail carrier, and
Mhm.
the mail carrier might not come to care planning meetings, but you could maybe have them write a note that then really cheers the person up. You never know what people are going to say.
Yeah, yeah, so true. So it sounds like it should be on our minds to make sure we know who should be there, who are the key support people for each patient that we're taking care of, and has the proper paperwork been done to ensure that the right person to be a decision maker has been given that power legally.
Yeah, precisely. There's a lot of work to do to be sure that you're really educating clients, and making sure they're feeling empowered to advocate for what they're looking for.
All right. So that takes care of one issue that I wanted to ask about, which was making sure that partners are able to be and other important people are able to be part of the decision making process for the patients. But I wanted to ask you too if there are special issues facing LGBT people with dementia as well, because I know that's one of your areas of focus.
Yes, absolutely. So one thing to note is that some of the research that's beginning to show what might be possible causes of dementia do correlate disproportionately with LGBT folks. So what I mean specifically is that some members of the LGBT community or some sectors of the community are more likely to use alcohol and other substances, are more likely to be living with depression, are more likely to have experienced adverse events or traumatic events. And there's some literature that's beginning to link those things to an increased risk of certain forms of dementia. In fact, there's a researcher out of the University of California, San Francisco, who's using a pretty large data set to begin finding some compelling evidence that LGBT folks do experience certain forms of dementia at higher rates than non-LGBT folks. So that's the kind of first thing to say. But once someone does have a diagnosis, there are some really unique things that they encounter. So for example, some people living with dementia become kind of hypersexual, and others might not be hypersexual or inappropriately sexual, but they are still looking for physical affection. And staff and loved ones have to begin to figure out if there's an appropriate way for those needs to be expressed. And one thing that we've seen is that people whose sexual expression is for someone of the same gender are often judged or policed more harshly. Their behavior is seen as being shocking or surprising or predatory, when in fact it might be an appropriate expression of a desire or a need that somebody has. So what this looks like in practice is that the kids come to visit their father in the senior living community, and they see him holding another man's hand, and they just assume that that person is taking advantage of their father because they've never known him to have any interest in other men in an affectionate or sexual way. So one thing that we really train staff to do is to prioritize the needs of that resident. And depending on how far they've progressed in their disease process, it might be that it's a latent identity that now they're expressing because their kind of barriers have fallen down. Or who knows, it could just be that they really like this person and they want to show their affection for them in some way. So we can't necessarily assign a label to the behavior, but we can understand that sometimes family and staff will react disproportionately intensely to behaviors that would be commensurate with LGBT identities.
So that's interesting. And that sounds like something very important for people in facilities to know who are working with patients. And I wanted to talk as well about caregiver issues because I know in general the baby boom population is really facing a critical shortage of caregivers in the future, but I imagine that's even more true for the LGBT population as well.
Yeah, a couple of things to note is that LGBT older people are less likely to have children and they're more likely to be isolated. So there are fewer people who can step in to provide informal care. And oftentimes, the people who are providing that informal care are friends or members of the LGBT community, but not necessarily biological or legal relations. So it's important for providers to learn how to recognize those folks and treat them, with the same respect and authority that they would a related caregiver.
Well, I was just going to ask you, I know at Sage you're working on various initiatives. Do you have any initiatives in terms of caregiving or meeting the shortage of caregivers?
Most of our work on caregiving has been to either educate professional caregivers, like in an institution or facility setting, and then also educating our constituents on how to prepare for their eventual needs for care. So we've created some documents and educational campaigns that are meant to help people begin thinking like, I might in the next 5 or 10 years need a little bit higher care. How do I begin getting connected to my community and asking my friends and loved ones if they'll be willing to step in and help? So we've tried to kind of approach it through those two ways.
And I noticed that you have, it looks like a few handouts available or on the Sage website.
Yes, the SAGE website, sageusa.org, has a lot of information both for providers and for LGBT older people. The other resource that I would point folks to is the National Resource Center on LGBT aging, which is at lgbtagingcenter.org. And they have a ton of best practices and guides, but also an entire section about caregiver and caregiver needs.
All right. I think that could be really helpful. I see that as something that we're going to need to address in the next few years, making sure that we have enough caregivers and also that they're well trained in working with LGBT patients.
Yes, and I would add well paid as well. It's hard to expect someone to provide really person-directed, deep, often emotional care for people in their charge if they're also being forced to work, 3 jobs to make ends meet.
Oh, you're so right about that. We need better pay for professional caregivers and then pay for family caregivers as well. That's a huge need.
Totally agree.
So, I wanted to ask you a little bit more about us in the hospice and palliative care movement as allies for the LGBT community. And what are some things that we can do to be better advocates for better care?
Yeah, and I'm so glad you used that word ally. So just for any listeners for whom that might be a new word, the word ally, or when you say LGBTQA, it's often it is meant to designate somebody who themselves does not identify as LGBT, but who's a supporter of the community. And I love our allies. There are a lot of really dedicated LGBT folks doing this work, but we need all the help that we can get. So there's a lot of room for allies to be doing that. So to answer your question a little bit more specifically, I think educating yourself and advocating for training at your organization is definitely the best first step, because it often teaches you things that you didn't know you didn't know. And now you can begin to kind of incorporate that into your work. The next thing I would say is to, not be afraid of it. These are folks who are dying and they're looking for help kind of integrating their life experience. They're looking for care. People are re-entering their lives in a way that might be confusing, but can also be really beautiful. So if there is tension, for example, between a partner and family, or if there is a relationship that becomes divulged that nobody's known about. Whatever the case might be, it could be really uncomfortable in the moment, but those moments of discomfort are an opportunity to educate people and to help bring people closer. And I think there have been a lot of folks who have really benefited from the work of caring hospice professionals because they've allowed family members to achieve a certain sense of resolution and closure in what can otherwise be a very difficult time.
Oh, thank you for sharing those ideas. And you did mention training. So I wanted to ask you about the training I saw offered on the SAGE website. And could you tell us more about what that consists of and how to access that?
Yep, absolutely. So as I mentioned before, all of our training work happens underneath a program called SAGE Care. And it's a training and credentialing program. So organizations that meet certain thresholds in terms of the percentages of staff that they train annually will then earn a SAGE Care credential that has our name on it. It carries the weight of our name and our brand, and it tells people who are looking for services, if you approach this organization, you'll be interacting with staff who have been trained. Our trainings are, we have a half-day session that we typically do for the senior leadership of an organization, and that's where one of our SAGE Care trainers will work with them in person to both go through some curriculum about best practices, but also do a little bit of strategic planning. And then we augment that with a whole suite of 1-hour trainings that can be done in person, they can be done online with a live facilitator over a webinar platform, or we also have on-demand training tools that organizations can put on their training platforms. And those cover things like working with LGBT older adults in residential settings, aging as a transgender person, working with people living with HIV. We have a whole bunch of those 1-hour seminars. And while we don't yet have a specific 1-hour training tailored to working with hospice care, we have started working more and more with hospice providers and are beginning to get a sense of what their common questions are and the information they find most useful going out into the field.
This is excellent to know about because, for one thing, hospice and palliative care organizations are always looking for continuing education for their staff. And so to know that they could get access to some training through SAGE, I think would be very helpful. They don't have to try to create a curriculum themselves, but they could tap into the resources that you're offering. And it would really make a difference, I believe, for their staff to have this education.
Yeah, and I'll say too that I have been so impressed with the people I've worked with who come from hospice and palliative care. I'm speaking broad brush generalization here, but sometimes when I go into a training room, I really have to kind of get people moving and thinking about the importance of person-directed care and putting their own feelings aside to meet the needs of the client or patient. Some people really struggle with that. But there's something about folks who have worked in hospice and palliative care that they get that stuff straight away. And what they're looking for is the information they need to really be connecting with people and to be doing the very emotional labor of helping someone in the dying process. So I'm not trying to butter up your listeners or anything like that, but I really have enjoyed the work we've done with hospice and palliative care so far, and I'd love to continue doing more.
Well, I think you're very right about that. There's something really special about hospice and palliative care that more than any other specialty, you enter into the patient's life, really. I mean, you find yourself in the middle of life with that person and their family and this ordeal that they're going through. And so I would say in general, the hospice providers I know sincerely want to be able to do the best job they can and give the best care possible. So the more they have tools and resources to use for a diverse population of patients, the better it is. And actually, the less stress those providers experience. Because when you have an understanding of what to offer and how to offer it that fits the needs of the patient, it makes the job much easier to do.
Yeah, absolutely. I could imagine a situation where if nobody in the room feels comfortable naming the LGBT component, the provider might be thinking like, oh, there's all this tension in the room, but what's going on? Like, how do I get access to help people here? But if they do create that space where people feel comfortable bringing their full selves, it then allows you to take that discomfort and work through it and use that as a part of the process.
Yes, it's so true. And just having the training really gives people permission to go there, permission to ask the questions and have the discussions and to get over any discomfort that might have been there before.
Yeah, exactly. And as I kind of noted before, I think, most people will understand and feel and appreciate if they're interacting with somebody who has their best intentions at heart. And they'll be able to feel that you're there to partner with them. And, it might be the case that you don't know exactly every term to use, or you accidentally use the wrong pronoun and have to correct yourself. But if you've laid that foundation of care and communicated that that's what your goal is, I think that the clinician and the client will then develop a relationship that's sufficiently supple that if there are any missteps along the way, they can be addressed and won't, fracture the relationship or make someone feel like they need to recloset themselves.
Yes, exactly. And I think also because a lot of what hospice and palliative care workers do is interact with family members and try to help overcome conflicts and divisions that have happened in the family to, as much as possible, help people come together. But I think in the case of LGBT people and their family relationships, it's really important to have a deeper understanding of what might be behind some of those conflicts.
Absolutely. And, one thing that I'll note here that we haven't touched on yet is that I should say, and people should be attuned to the fact that there's quite a bit of ageism within the LGBT community. LGBT culture is oftentimes a little bit youth focused. There are aspects of the LGBT community that are very concerned with physical appearance and sexual desirability. So I bring that up to say that when working with LGBT clients, there might be a particular way in which they've internalized negative feelings and kind of ageist assumptions about what it means to grow older, they can expect from the dying process, who will come and visit them. It might be the case that they do have friends from the LGBT community, but those friends will say things like, oh, I can't bear to see you this way. So another component of this will be working with them to challenge those beliefs and challenge those friends to step up. And yes, this is going to be uncomfortable, but in this moment, this person who's dying really needs their community and needs you to meet them where they're at.
Oh, that's very interesting. That's something I hadn't thought of. So I'm really glad you brought that up, because a lot of us in this end of life arena are trying to figure out, how do we help people have more meaningful and productive conversations about aging and about death and dying and about grief as well. And so it's important that we also think about the LGBT community, and are we doing any outreach there to help those people also have the same conversations that they tend to be difficult for all of us. But it's really important that we help people start to be able to share with one another and talk about those issues together.
Yeah, absolutely. I mean, I'm very serious when I say that I've done hundreds of presentations for non-LGBT audiences that were super resistant to my content, deeply politically opposed to LGBT inclusion. And those things are no sweat compared to going into an LGBT center to say, you need advance directives in order because we're all going to die one day. That conversation does not go over well with that audience.
Well, that's interesting. So, that is an interesting challenge for us to think about, because we know that the end of life goes better when people have talked about it and thought about it and been able to have these conversations. So it is something we all need to be working toward as well. And maybe we need to be coming together to brainstorm about how can we do a better job with that population of people.
Yeah, and I think it's an opportunity for people to think really creatively about the kinds of communities and families that they want to create intentionally. So, if I'm working with a pretty isolated LGBT older adult who might not have anyone, that he wants to put down as his next of kin, or anyone he feels comfortable being the power of attorney. Like how beautiful and meaningful would it be to then use that time to help really explore the relationships that he does have and see if any of those relationships are deep enough that he would want to ask somebody to, if not become power of attorney, which is, I mean, that's a very big decision, but if only to identify the 5 people who he'll want contacted if he goes into the hospital to come and visit him, to let people think creatively about what a family means and how we can show up for one another when we're vulnerable.
Yes, exactly. And I saw on the Sage website something about Sage Table, and I wasn't sure. Would you tell me more about what that is? And is that a venue that could be used to have these conversations around death and dying too?
Yeah, so Sage Table is a program that we created a couple of years ago to try to reduce isolation by creating intergenerational connections. So the idea is pretty simple, which is that as a host, you commit to hosting a meal. And that could be a picnic, it could be hors d'oeuvres, it could be a 15-course meal, whatever it is that you want to put together. But then you work with Sage and in your community to advertise that meal and get a multi-generational group together of LGBT folks and allies to talk, to chat, to talk about their experiences, to explain what it feels like to be LGBT at their age. We have a number of different prompts, but the goal is to create venues for those kinds of conversations and relationships to build. So I don't know if it's exactly the right venue for a conversation that would get quite as deep as death and dying, but I think it's the right venue to begin forming those groups who then over time could continue meeting to have those more kind of deeply private and possibly hurtful, not hurtful to each other, but difficult conversations.
Yeah, I really like that idea. And you've probably, I don't know if you've heard of Death Over Dinner, which is a movement to bring people together for dinner specifically to talk about death. But so I'm just in my mind, I was imagining, could we morph those two together somehow? But I see, to start with Sage Table as it is and just bringing the intergenerational groups together, that seems groundbreaking, just to be offering that.
And they're really fun. I've been to a number of Sage tables, and you get a bunch of generations of LGBT people together, and they're going to be telling stories and teasing each other, and end up knowing all the same people, and they didn't realize it. You never know what kinds of conversations are going to come out of those meetings.
Yeah, and so you mentioned including allies as well, and it seems like that's a really valuable setting for an ally to become part of also, just to have a deeper understanding of the community and maybe even to become more aware of how to be a better ally.
Yeah, I think that's right. And, as an ally, to think like, I'm going to go to this and I'm just going to kind of hang back a little bit and listen and absorb and, hear the experiences that people want to be sharing. Exactly as you said, to then inform your perspective and get a fuller picture of what it means to be LGBT.
Yeah, definitely. Okay, well, maybe it's too soon for Death Over Dinner, perhaps at this point for the LGBT community. But as you said, maybe that's something that would develop if a group of people over time had multiple dinners together, and who knows what topics might come up down the road.
Yeah, no, I think it's an excellent suggestion, and I certainly don't want to put it on the back burner too quickly. So I'll take it back to the Sage Table team, but I think it could be a great venue for having those deeper conversations.
Yeah. Well, I also wanted to ask you, Tim, about your book. I know you've written a couple of books, but the one I wrote down that I was interested in is Welcoming LGBT Residents, a practical guide for senior living staff. So would you tell us a little bit about the book?
Yeah, absolutely. So I've been doing trainings and kind of in this field for about 6.5 years now. And a lot of people who work at Sage work directly with LGBT older adults, but almost all of my job involves working with folks who are largely unfamiliar with the LGBT community and getting them the information that they need to then work with our constituents. So it occurred to me I guess now 2 years ago or a year and a half ago, that while there are best practice guides out there, there wasn't just a kind of single resource for anyone working in senior living who's interested in this topic. So the book is really appropriate for, CNA staff, dining staff, administrators, HR. I've tried to write it in a way that's really approachable. And also, yes, I have best practices. Yes, I have very strong suggestions on what is the best way to create an inclusive environment. But I wanted to write a book where nobody felt judged coming to the book. So if you really don't know anything about the topic of LGBT inclusion, even if the topic makes you uncomfortable or you kind of have some feelings about engaging with it, I wanted to create a book that would create a space for that reader and not only give them information, but hopefully get them excited about the role that they can play in creating more inclusive spaces for LGBT residents and also for the LGBT family members of their non-LGBT residents.
So it sounds like it's a book that could still be helpful to outpatient hospice and palliative care providers who they're not part of a facility, but even those making visits to patients in the home. It sounds like there are tips and suggestions that they could gather from the book as well.
I think so, yes, because quite a large part of the book is explaining what it means to be LGBT, specific needs and fears. There's a chapter on HIV, there's a chapter on memory care. I think a lot of it would apply to folks who are working in outpatient settings or especially in residents' homes. So I definitely think that there is use for folks beyond just the realm of senior living.
And so, where can people get a hold of the book?
I don't think it is yet in any brick and mortar stores, but it's in all of the online bookstores, Barnes and Noble, Amazon, or they can order it directly from the Rutledge website, who's the publisher.
Okay, and so it's called Welcoming LGBT Residents, a Practical Guide for Senior Living Staff. So if any listeners out there want to get a hold of that, you know where to search. And I'll put a link to the book in the show notes as well for anyone who wants the book, because it sounds really helpful. But also the Sage Care training that we were talking about, people can just go to the Sage website to get information about it.
Yep, they can link to it from the Sage website, or we have our own website just for Sage Care, which is sageusa.care. And there they can get more information on what the program looks like. And if you're interested in getting a personalized training plan that our team would put together after doing an intake with you, you can navigate to the Get a Quote section of the page, and that's how you would start the process of engaging with the program.
And that sounds like an excellent resource that I would love to see all of the hospices out there taking advantage of.
Yeah, and we will work with every single one of them.
Yeah. Well, thank you. And then again, there are other resources on your website. I noticed you have a hotline, and there are, other things to download and look at, and a connection to the other website that you mentioned as well.
Yeah, the LGBT Aging Resource Center.
Yes.
Which is a great resource. And our hotline, as you mentioned, is now up and running again. And the primary audience for the hotline is LGBT older people themselves who want to call in with a question or just to have someone to kind of chat with if they're feeling lonely or a little bit blue. But a lot of providers call that number too, if they just really don't know who to reach out to directly to get local resources or more information. The staff who run that hotline have been trained by us to help people navigate the network of resources that are out there.
But it might be something we could offer to patients if we recognize a patient has a need to feel a little bit more connected. Maybe the hotline is something that would serve the needs of one of our patients.
Yeah, I think that's right. And that just reminds me too of another program I didn't highlight, but we have a friendly visitor program. It currently only runs out of 2 locations, New York and Fort Lauderdale. But if we don't have a friendly visitor program in your area, there very well might be a local LGBT center or a university LGBT group. We've even had some organizations have really great experiences matching high school students who are looking for volunteer hours with older adults who are looking to build a kind of social connection. So there are a lot of opportunities to try to get people who might be more isolated integrated into local communities and networks.
And that's good. And just something for us to keep in mind as we're working with patients to think about isolation as an issue and make sure that we're addressing it and helping people connect wherever they can.
Yeah, absolutely. And helping people to feel empowered that they, even, and I would say especially at the end of life, have the right and the ability to be connected with other people.
And so, Tim, are there any other things that we should know, those of us who want to be allies and advocates, any other issues, any other places where you can use our help or use us to get involved either in SAGE or locally in our own communities?
Yeah, I think, in addition to the programs that I've discussed, if your listeners are interested in anything in particular that I've mentioned, they can reach out to me directly. Please feel free to put my email in the show notes so that people can get a hold of me. But speaking generally, this is one of those topics where if people aren't talking about it, things might get worse. If we're not constantly thinking about the needs of LGBT elders, what we can do to be proactive, we don't want to see things go backwards, where it becomes a kind of don't ask, don't tell atmosphere. So I think, for the allies who are listening, you all are completely integral to me and us being able to do our work. Because when you go back to your organizations and you say, listen, I'm really concerned about this LGBT topic, I found these resources, we got to get in touch with these folks, that allows me then to enter the room as a resource rather than entering the room as an advocate who's trying to say like, hey, let me in to talk to your folks. So the more that you all can be doing to keep this centered as a real concern in the work that you're doing, and then also to educate yourself and be an advocate locally and within your organizations, that's what will really then help us at the national level to continue doing this work.
And really, we still have a long way to go toward more inclusive healthcare settings and systems where everyone feels at home and feels that they belong and are getting the care they deserve to receive and also being treated with the dignity that they should have. So remember that we still have so much territory to cover. So all of us need to become more aware and be noticing what's happening for the patients we're caring for.
Yeah, I think that's right. And I think if anyone listening is feeling daunted by the big picture of where we need to go, which I agree with you, there's still a long way to go. Never forget that just making small changes to how you do your job on the day-to-day can have an incredible impact on the people you're working with directly. So we all need to work together for the big picture fix, but there's a lot we can do to make sure that the individuals that we're interacting with are feeling supported and affirmed and having a good experience.
Mm-hmm. Well, Tim, I want to thank you so much for sharing all this information with us. This has been really enlightening, and I think that it will be very helpful to a lot of people out there listening.
Yeah, I'm excited. Thank you so much for the opportunity, and thank you to everyone listening, and go out there and get it done. You can do it.
Yes, absolutely. Well, this is what it takes, is being willing to talk together and sharing our ideas and just recognizing we all care about the same issues. We want to make things better. And so the more we overcome our fears of connecting and talking about it, the better off we'll be moving forward.
Yep, I couldn't agree more. Very well said.
Well, good luck to you, Tim, and good luck to Sage as well. And I'm interested to keep following along and seeing what other ideas you come up with.
Great. Well, thank you very much, and thank you for the opportunity.
You're so welcome. Take care. Well, I hope you enjoyed my interview with Tim Johnston of SAGE. I was very excited to learn about this SAGE Care training that their organization is offering to improve the cultural competency of hospices, long-term care facilities, nursing homes, in terms of caring for LGBT individuals. I think it's training that's desperately needed right now, and I can only imagine how many individuals from this community are trying to get services and nervous and frightened about the way they might be treated. And I did read a statistic on the SAGE website that said that 9 out of 10 LGBT individuals fear that they'll be discriminated against in medical settings or any type of care setting, and therefore are afraid to talk honestly about their situation. So that's something we really need to change. We need to move the needle forward as we try to provide appropriate care for everyone, for every patient who needs our services and comes into our midst. So if you belong to an organization that could use training like this, go to the website sageusa, SAGEUSA.org, and look up SAGE Care training on that website and learn how you might access it for your organization. I think it would be well worthwhile. Well, thanks again for tuning in today. And I hope you'll remember that there's a new episode every Monday, so keep coming back again to listen to new topics of discussion here. I'm very eclectic in what I try to offer you, so there's always something different and hopefully unique that you can hear on this podcast. If you enjoy this content, please consider sharing it with someone else who might benefit from it. Subscribe on Apple Podcasts, Spotify, Stitcher Radio, or iHeartRadio. And if you're so inclined, leave a review for the podcast wherever you're listening, which can always help other people find this information. So until next week, remember, we're here for love. So face your fear, be ready for whatever life brings your way, and love every moment of this beautiful and precious life. Bye-bye.